Okay, thank you all for coming. We're going to give it a little bit more time for people to trickle in, but then I'll give you our announcements and we'll start the panel. Okay, I'm going to go ahead and get started with the announcements. Welcome to the 2021 Water and Health Conference. Thank you all very much for coming, and thank you in particular for coming to this event. I'll be your room host for this session. I'm Catherine Conaway with the Water Institute at UNC. Before we can begin, we have a few announcements. First, we have a networking and sponsoring event this afternoon that we'd invite you to go to on Remo. And further instructions on that are available on the conference website. Next, we also have a trivia night tonight. We'll be asking trivia centered around this week, what we learned this week at the conference. This is also available on Remo, so we hope that we'll see you either here or at the networking event, hoping the trivia night will be a lot of fun. Next, we will have some technical reminders. This event is recorded, and you'll be able to go back later and view it on the Pathable platform. As well, we also have disabled the Zoom chat. So we're going to ask you to send any of your questions you may have for the panelists into the Pathable Zoom chat. So the same window you got, the same window you used to get into this meeting, you'll use to place your questions for our presenters. So finally, that's all of our announcements. So we just have our presenters today, and our first presenter for this event is going to be Cynthia Fosuah and Suglo Kombo Ibrahim. So if the tech would share the video, that would be great.
Hello, welcome to our session. My name is Cynthia Fosuah. I'm making this together. We are delivering on the topic titled Delivering Transformative WASH at Scale, using the Nurturing Care Group as a vehicle for high frequency messaging, norms change, and driving collective action. Behavior change is hard. It is also difficult to achieve, especially when it requires a collective action by a community or the creation of new norms by an individual. Mostly, WASH behaviors are termed as a public good because they are usually a community performed action or a collective action that needs to be performed by entire community to scale it up. For that reason, any approach that focuses on just awareness creation may not work. It therefore requires a robust approach that is systematic, consistent in messaging, and has higher frequency. Today, we want to share with you an approach called the Nurturing Care Group approach, an approach which has high consistency and coverage used by volunteers in a community to teach WASH lessons which are further cascaded to mothers in the community. My colleague Suglo Kombo will follow up with the results of our study. Thank you.
Thank you so much, Cynthia. As indicated, I will share on the results, but before then, I'll touch briefly on our methods. In this study, we conducted a controlled before and after trial to ensure that we maximize the objectivity when assessing the contribution of the Nurturing Care Group model to WASH behavior change at the household level. This was done in 2 districts of Ghana, Sablugu district in the northern parts of Ghana and Setra East district in the southern parts of Ghana. Over baseline and end line, we engaged 324 respondents in the intervention area and 430 respondents from the control area. We assessed various WASH behaviors, including water handling at the household level, latrine construction and use, hand hygiene, among others. We collected knowledge and self-reported behavior from respondents, and where feasible, direct observations were also made, including testing of microbiological components of stored drinking water at the household level. Over baseline and end line, changes were seen in higher proportions in the intervention area than the control area. For instance, households with detectable E. coli in stored drinking water saw a decline by 24.1% in the intervention area compared to a 1.8 change in the control area. It is relevant to underscore that relevant indicators like households who covered their drinking water, stored their drinking water beyond the reach of animals, among others, increased in higher proportions in the intervention area than the control area, contributing to improving the quality of household stored drinking water in the intervention area. Also, access to basic sanitation services also increased by 15.5% in the intervention area compared to an 8.7% change in the control area. This gives us a net change of 7%. This could be small, however relevant, considering the challenging situation of sanitation in Ghana currently. Open defecation stands at about 19%. Again, access to basic hand washing services also increased by 52.6% in the intervention area compared to a marginal increase of 1.7% in the control area. The significant change in the intervention area is commendable, considering the essence of hand washing in combating infection prevention and control, especially in this dispensation of COVID-19. In conclusion, it's worth noting that group-based approaches that are structured with frequent messaging that targets every household in the community can lead to WASH behavior change at the household level. It is relevant that WASH implementers will complement their WASH programming with behavior change approaches like the nurturing care group model that has evidence to underscore that it works, to ensure that households acquire and use improved WASH services as we all put our efforts together to achieve the Sustainable Development Goal 6 by 2030. Thank you.
Thank you so much for that presentation. Now, if anyone has any questions, please, I encourage you to put them in the Pathable chat box. I have a few questions which were on this presentation, which were, I sort of wanted to know more about the water sources in this location and what was the pre-existing access to water in the location before at the baseline.
Hello?
Hello?
Hi.
Hello?
Can we respond?
Yeah, please respond.
Oh, okay. The
Yes.
various water sources within the intervention area and the control area mostly were boreholes with hand pumps, and very few communities, especially the ones in Central East that are in the southern part of Ghana, had communal taps. Those were the main sources of water for the communities in both the intervention area and the control area. Over baseline and end line, access to water did not increase significantly, even in the intervention area. We experienced a marginal increase of about 1%. This is so because access to water does not, typically in the Ghanaian context, it is not the household that provides its own borehole. it is the government or an NGO that provides a borehole for a community. That is mostly commonly used in the rural context in which this study was done. Now, the nurturing care group model is a model for WASH behavior change at the household level. And so the challenge is when it comes to access, that is not dependent on the household to provide. For instance, if the borehole doesn't exist and the behavior has changed, then it will be a challenge. That is why the NCG is necessary to complement the ongoing measures, especially that is infrastructure provision. However, when it comes to sanitation, when you compare, you would see that it increased by 15.5%. That is because with sanitation, the onus lies on the household to provide the facility themselves. And so when you do structured targeted messaging and education, households would eventually construct and use their own latrine facilities. But with water, it will have to be provided by the government, an NGO, or collective body, but not an individual community. So the angle here for water is on the quality of stored drinking water at the household level, which has to do with behaviors on how water is handled, how water is used, how water is stored after it's collected from the communal source. So the targeted education under the NCG model was to promote proper storage of water at the household level, which contributed to ensuring that E. coli contamination was reduced by 24% in the intervention area compared to 1.8 in the control area.
Great, thank you. We have one question from the audience, and then I think we're gonna, after this question, we'll need to move on to the next presentation. This question is, what are the lessons from other countries on the acceptance of sanitation products such as manure made out of fecal waste that you think is relevant for this project?
I'll come again. Yeah.
Sorry,
Can you say the question again, please?
Yes, so it's what are the lessons from other countries on the acceptance of sanitation products, such as manure made out of fecal waste, that you feel is relevant for this study?
Hello, I lost you at some point. Can you come again on the question, please?
Yes, sorry, I'm just gonna put it in the chat, in the Zoom chat for you to see, but it's from the Pathable chat, audience member from the Pathable chat.
I would come in and Cynthia would top up. I got a bit of the question. So this study did not explore the acceptance of the reuse of fecal waste from sanitation facilities. The focus under this study was on promoting the construction and use of latrine facilities at the household level. Now, this promotion did not also have lessons targeting households on the reuse of fecal matter from the latrine facilities. However, generally, in a different experience, not this particular one, generally there have been some sort of reservations about the reuse of fecal matter. However, I think that it is important, and with structured education through the nurturing care group model, I think that we can get households to begin to appreciate and also see the essence of the reuse of fecal waste. However, this should come with very robust infrastructure that will come at an increased cost. And so we might have to look at very good financing mechanisms for households to be able to afford these kind of latrine infrastructure types, and also make sure that education is very strengthened so that we do not have situations of contamination of water or other things in the household from the fecal waste. Thank you. Cynthia, you can add up.
Oh, we kind of need to move on to our next presentation. We sort of run out of time for this one, but thank you very much for your presentation and the questions and answers. Could we share the next video, please?
My name is Joyce Kisiangani and I work with the Acquire Institute. This program, the impact of targeted pro-poor sanitation subsidies within open defecation-free communities in Northern Ghana, is a research collaboration between USAID WASH Pulse, who is the research partner, and UNICEF Ghana, who is the implementing partner. Globally, there's growing evidence that the poor and vulnerable do not always benefit from CLTS programming. And so this study evaluated a targeted subsidy program that served as a follow-up to CLTS to support movement up the sanitation ladder, especially among the poor and vulnerable. The targeted subsidy program was implemented by UNICEF Ghana, and the targeting approach used a community consultation method whereby district assembly officials facilitated entire communities to identify who poor and vulnerable households are within the community. After this, households that were identified through the community consultation received a voucher that they could redeem with the local artisan to access a durable latrine substructure that was fully paid for. We conducted a cluster randomized control trial in 109 open defecation-free communities in Northern Ghana, and 59 of these communities were in the treatment and 50 were in the control. We then conducted community consultation to identify eligible households and those that were not eligible within all the communities. And in the treatment group, eligible households received a voucher that they could redeem for a durable latrine substructure. We also conducted baseline and endline survey to determine latrine coverage, quality, and use within all our households in the 109 communities before and after the program. From our surveys, we had 4 main outcomes that represent sanitation outcomes that are represented by each of the columns in this first graph: open defecation, toilet coverage, durable toilet coverage, and durable toilet that is not shared coverage. So this graph shows how these 4 outcomes changed over time, that is from baseline to endline. The rows represent the change over time for all households, the top row, for only voucher eligible households, the middle row, and for non-eligible households, the bottom row. So overall, we saw deterioration in sanitation conditions among our study communities post-ODF, as you can see on the top row. The subsidy also had large impacts on the voucher eligible households within the treatment group compared to voucher eligible households within the control group, as you can see within the middle row. Finally, the subsidy had impacts on some non-eligible households, and this was through sharing of a subsidized toilet within the same compound. On costs, we compared costs on 2 scenarios. So the first one is on CLTS followed by the subsidy program, which is within our treatment group, and CLTS only, which is within our control group. For each of these scenarios, we looked at the proportion of households that were benefiting from the intervention and the cost associated with this. In this table, you are looking at 3 interventions, and we are looking at the number of households that benefited from each intervention. That is, number of households that are no longer practicing open defecation or have upgraded from an undurable toilet to a durable toilet. And then we are estimating costs associated with this for each of the benefiting households. So we found out that more households upgraded from a non-durable to durable toilet or stopped open defecation in the scenario where the CLTS program was followed by the subsidy program. However, this was at an extra cost. So this means that adding the subsidy benefits more households but at an additional cost. In conclusion, the deterioration in sanitation conditions indicate a need for an additional program post-CLTS, and the subsidy program helped to lessen this deterioration, but it failed to create a demand for the durable latrine substructure among non-eligible households. Finally, we recommend that future programs that do targeting include vulnerability criteria that are more likely to identify households that are less likely to have a toilet. Thank you.
Thank you so much. Joyce, if you could share your poster, and then if anyone has any comments, please, or questions, please put them in the Pathable chat. I do have another question for you, which is about how long had communities achieved ODF status before the baseline of your study, and how long after?
Yeah, so our communities had achieved ODF status between 3 to 32 months before we conducted the baseline. And for the end line, it was between 1.8 to 4.4 years before we did our end line. So the timelines that you see on the graph here are between baseline and end line, which is approximately 17 to 24 months. Thank you.
Great, thank you. And we have one question from the audience, which is, instead of paying for targeting the subsidy, would it be better to just give all the households in the area the subsidy?
Yeah, that's a good question. So the challenge with giving all households the subsidy is that there are households who can be able to afford building the toilet, but there are those who are extremely poor and cannot completely afford to get these durable toilets. But unless your program, you have enough money to spend to give every single household in the community's toilets, but targeting essentially and is for those who are really poor, who cannot afford to get a durable toilet, so that they can upgrade from, so that they can stop open defecating and at least use a toilet that will sustain them for a long time. In addition to this, targeting also kind of, our program was not like conventional programs, which would just come to a community and give everyone toilets. And so in the past, you've seen a program that you just come to the community and give everyone toilets. But at the end, when you would go back to study, you would still find that there are some people who are still not using those toilets. And that has issues to do with ownership. When you're just giving out these things for free, are these people getting it? Are they getting ownership for these toilets? Or would they end up just saying that these are things that these are toilets that a certain NGO came and built, and so we don't even know what you're supposed to do with it, we don't care about it. But targeting, when you're targeting and involving the entire community in the targeting methodology, you are also promoting ownership, because the people who are being selected by the community are extremely poor and really need this support. And so even when this program was only giving the substructure, and so that the household can put up the superstructure, even the subsidy itself was a partial subsidy. So this encourages ownership and enables the poor and vulnerable household to use the facility that you're giving them.
Great, thank you so much. And thank you to our audience for giving questions. Joyce, there is another question for you in the chat, but we don't have time to answer it during the video. So if you want to go back later and answer it on the chat as well, you have the option to do that. With that, we're going to move on to our next presenter. That's Rosie Sanderson. So if our tech would swap to that video, that would be great. Joyce, you may need to stop sharing. Thank you.
Good morning, good afternoon, everyone. Welcome to this poster presentation. Thank you for coming along. My name is Rosie Sanderson. I'm a project research officer with the International Water Centre in Brisbane, Australia. And with me is my colleague, Clement Lifoya, who is from the Solomon Islands National University. You have found yourself into a poster presentation all about children's poo. You might be asking why we should care about how parents around the world deal with their kids' poo. And we're here to say that it's been recognised as a gap in the way that we talk more broadly around sanitation, and particularly around open defecation. With this in mind, we at the International Water Centre and Solomon Islands National University partnered with the London School of Hygiene and Tropical Medicine to explore the behavioural determinants of the management of children's faeces in rural Solomon Islands, where sanitation coverage persists as an issue more broadly, and in particular, there's a lack of attention on children's faeces management. We have prepared this poster for you, which reports on the outcomes of our formative research, which we have just recently completed. Thanks, Clement.
Thank you, Rosie. Our research method is a cross-sectional qualitative study designed in 5 rural villages in Solomon Islands across 2 provinces that had participated in CLTH programs, and in each village, all households with children under 5 years old. Our research team comprised of 2 female and 2 males, including myself as a researcher. We had interviewed mothers, fathers, grandmothers, and village chiefs with a number of different interview and discussion group tools, including using purpose-designed visual picture card prompts for different behaviors. Our data collection tools were developed using the behavior-centered design approach, which says if you want to affect a change in behavior, something needs to change in the environment, which changes something in the brain on the body of the person, which then influences their behavior. To do this, we obviously need to understand those important influences of brain, body, and environment. For our results, out of 139 respondents, including 109 caregivers, and 30 village leaders or community members. Of these, 61 caregivers participated in structured recall demonstration of the last time their child defecated, where 48% of the feces ended up in the latrine. Only 35% of examples of when a caregiver had to physically move the shit out from where it is could be considered to be practicing safe CFM.
Thanks, Clement. So after we've found out what the existing behaviours are, we were really interested in the reasons why people did or didn't perform safe CFM behaviours. So we've presented our results in line with the BCD framework as well. So issues to do with the brain, issues to do with the body, and issues to do with the physical and social environment. Now, we found that in general, parents were most motivated by a desire to nurture their children, so to do what's best to keep them safe and happy and healthy. This motivation was supported by disgust at seeing other children's feces lying around and a certain sense of affiliation with the community to keep their communities clean. These were all reasons that respondents put forward for practicing safe CFM behaviours. We also found that, like many hygiene or WASH-related behaviours, a lack of knowledge was not the issue here. So people could talk to us about the linkages between disease and feces and vectors and flies, but other barriers such as time and workload pressures, latrine convenience, accessibility, location, and having the appropriate tools at hand were all different barriers that cause people not to perform safe CFM. From here, we are recommending that the gap in sanitation policy is addressed through behaviour change campaign work, and that should be informed by nurture motivations, filling smaller knowledge gaps, such as whether or not child faeces are more or less harmful than adult faeces, addressing some of the barriers and convenience factors, and supporting the formation of safe CFM habits within communities. Thanks very much for your time.
Thank you so much for that video, Rosie. Now we'll have questions from the audience. Please put any questions you may have in the Pathable chat, just like last time. I do have one question myself, which is, what do you think will be your next steps in this research project?
Thanks, Catherine. So this first part of the project, as we mentioned, is the first phase, the formative research phase. So it was really intended to be a deep dive into exploring some of those behavioural determinants. So hence, it was only through 5 villages. It wasn't a wide, extensive study. It was more intended to spend a significant amount of time in a few villages to really unpack some of these behaviours. And we've now moved with our partners into the second phase of the research project, where along with us as the research organisations, we're working with some of the CSOs in Solomon Islands who are, as part of their normal approach, they are undertaking CLTS interventions across the country in lots of different provinces. And so our current work is around designing complementary intervention, specifically around CFM, to insert into some of the CLTS programming that already exists. CLTS is the national policy for sanitation, rural sanitation in the Solomon Islands, which is why our focus has been around this part of the program as a way of trying to address some of these behaviours at scale.
Yes, another question is, like, these communities which you looked at. Oh wait, there is a comment from the audience. Could you reiterate what the change in the environment was and the recommendation that is beyond the results of CLTS? I'm not sure. You may need to, Ron, you may need to clarify what your comment is, but
yeah, I mean, I can talk a little bit to the environment. So when we say environment, we meant both the physical environment and the social environment, both of those being important. So the physical environment situation were things like some of the communities that lived more physically close to a stream or the beach or some body of water, which became a preferential disposal location for child faeces. So in terms of changes to the physical environment, that's obviously not going to change. So it's more, in that situation, it's more about having influence on the behaviours from a motivation point of view, and seeing that which location for disposal might be a better option. Social environment influences are quite interesting and quite strong in the Solomon Islands, in rural Solomon Islands. So we explored a lot around the leadership structure. So the influence of, in the Solomons, there tends to be 3 main leadership structures. So the chief of the village, the leader of the church in most villages, almost all villages, and then the head of the main committees. And so the influence of those different leaders on different behaviours to do with sanitation, including this one, is quite strong. So part of our intervention as well will be working with those leadership groups, the leaders of the Mothers Union, the leader of the church committees, those sorts of things. And the other social environment element that's really strong here is the social norms that say one way or the other. So yes, the feces should be moved as part of the social norm, because nobody wants to have feces lying around in the yard if there's visitors coming, that sort of thing. But the social norm didn't seem to extend to instructing parents how or what they should, where they should be disposing. So we don't want to go that far to instruct anybody. That's not our role, but we want to make some of those linkages within the social norms to facilitate and support more safe behaviours, which we have fairly limited, restricted to disposal in the latrine, which, you know, there could be some conversation and debate about that particular definition, but we're going with the WHO definition of disposal in the latrine as safe.
Great, thank you. And if anyone else has any other comments, they can feel free to put them in the Pathable chat, and Rosie will have the option to go back and answer them later, should she wish to. With that, we'll move on to our next presenter, Jessica Trippy. Great, thank you.
Hi, everyone. Thank you for joining this presentation on tailoring sanitation approaches in Kenya's pastoralist communities. My name is Jessica Tribbe, and I'm with the Acquia Institute and the USAID WASH Pals project. Today, I'm presenting on behalf of my colleagues, Edna Samuel and John Trimmer. This research was funded by USAID and conducted in collaboration with the USAID mission in Kenya. This research focused on trying to understand why community-led total sanitation, or CLTS, has had limited success in the pastoral communities in Kenya's arid and semi-arid lands, also known as the ASALs. In these communities, pastoral communities are communities who practice seasonal movement in order to bring their livestock to water and pasture. And these communities are not homogeneous, so some may practice maybe more highly mobile and move constantly throughout the year. Others perhaps have a permanent homestead that they come back to for a few months out of the year, while others are becoming more and more settled and practice agropastoralism instead. So the research had three main research questions. So first of all, really trying to understand what are the underlying factors and constraints affecting sanitation adoption in these communities. And then what are the acceptable standards for these communities to actually adopt sanitation? And finally, how might we adapt CLTS to better address the challenges associated with sanitation in pastoral communities? To do this research, we conducted qualitative interviews in 17 communities across 3 counties of the ASALs. To go to our findings, so firstly, we came across many common themes that have already been highlighted in the literature, so I won't go in those today, but those include things like water scarcity, poverty, and insecurity in these areas that already sort of exacerbate the challenges to latrine adoption. But we also found that there were specific constraints that were more linked to communities depending on their level of mobility. So for those communities that were more highly mobile or practiced partial mobility, we found more cultural restrictions that were really preventing adoption of latrines. Whereas in the more settled communities, we did not find the same cultural restrictions, but we still found challenges related to accessing materials and just having sort of harder to reach communities for CLTS implementers that were making it difficult to implement the programs. In terms of the opportunities that we found to actually bring sanitation to these communities, so overall, most communities do still want to have latrines, but these latrines, especially in those with more cultural considerations, latrines must meet their cultural requirements. For example, in some communities, there are specific family members who are responsible for guarding the livestock. These are called morans. And morans are thought to not defecate at all. And therefore, it is very taboo to even see them entering a latrine. In these communities, privacy is of the utmost concern. So No one wants to be able to see anyone using the latrine. So this is a consideration for how we design and site latrines in these types of communities. And also another key finding was that really for the very nomadic communities that really don't have a permanent homestead, they ultimately do see open defecation as their best option and are not willing to carry the extra materials required to build latrines as they move from settlement to settlement. Finally, we offer a set of recommendations for both governments and for implementers. For governments, we really encourage focusing on the enabling environment and specifically think about funding to sanitation in these counties where the needs and the budgets for rolling out sanitation programs is perhaps a little bit different than in other counties. Things like supply chains and transportation are going to be much more costly here. For implementers, we have one main recommendation, and that's to implement a very simple questionnaire alongside the pre-triggering process of CLTS. And this gives an opportunity to collect key information on, in particular, cultural barriers to sanitation adoption, but also to have a better understanding on previous programs that might have been in these communities and other challenges that communities are facing, so that the CLTS program can really be tailored to that specific community's needs. I won't get into the various examples that we provide here, but you can see them here on our poster. And at this point, I'm happy to open up to questions. Thank you very much.
Thank you so much for that video. Now we could share. Great. Now, if anyone has any questions for Jessica, please put them in the Pathable chat. I guess while we're waiting for those to roll in, could you speak a little bit more about the opportunities you saw for introducing CLTS in these communities?
Sure, thanks for that question. So I mentioned a lot of the barriers and the challenges here, but I think one key thing to mention is that we also really see that there is that communities are becoming more sedentary rather than there are of course still communities that are highly nomadic, but we see communities choosing to stay settled longer. And one of the drivers behind this is actually keeping their children in school and increase school enrollment. So one, this means that they are having, they're building more permanent structures so that some family members can stay behind for those children that are in school. It also, showed us that schools in general are a kind of an entry point for talking about sanitation, and that can be something that can be included in the pre-triggering process for CLTS.
Great, thank you. I guess I'm sort of curious about, I haven't read much WASH literature on this type of community. Did you guys look at like sort of other sources of other sanitation issues, like if they're practicing animal husbandry, like how they may interact with animal feces, or were you guys strictly looking at sort of latrine-based sanitation options?
That's a really good point. We didn't gather data specifically on exposure to animal feces. I will state that livestock in general came up this is one thing we talk about in sort of our opportunities section, that livestock are highly valued, of course, among these communities. And among some communities, there's a belief that actually their exposure to feces is dangerous for their livestock, which is not something we will try to prove or disprove in this paper. But I think the point is that people do see livestock as very valuable. And so protecting them and keeping them away from human feces is something that's a goal. And it's cited as a reason to construct a latrine and a reason to have a robust latrine that's not going to collapse, that will be safe, not only for their children, but also safe for their livestock to be around.
Great, thank you. I'm not seeing any, so one person just asked, and this will be our last question, then we'll be at time for the panel. But if you looked at menstruation at all in these communities?
We did not. I wish we had. I think that would be very interesting. Of course, not specifically, I will say. Of course, it comes up when we think about I noted the importance of privacy. And of course, this is something that is mentioned by women and women in our research did tend to be sort of the driver within the household for pushing for latrine construction, even if they aren't the ultimate decision maker. That tends to lie with the male head of household. But we did gather evidence that, of course, it's women who are really wanting and desiring the latrine. And I'm sure that is linked to wanting more privacy to handle menstrual hygiene.
Okay, so thank you. We've run out of time. The next series of events have launched in the conference, but thank you all very much, the audience and our speakers. Thank you very much for coming to the conference. I hope you have a good rest of the conference. I'm going to just share, for those of you still in the room, I'm going to go ahead and share our announcements again of, if you're looking for what to do next, we have a networking event that just started a couple of minutes ago, or is starting now in Remo. Share my screen. We have this networking event that's going on that just started. So you can go join that in Remo. And we also have a trivia night, which just started. So you can go run to that. And I'm hoping that's going to be a lot of fun. Yep. So those are it for our announcements. I hope you have a good rest of your conference.